Hi, my name is Matt Konkatan, and today we're going to be discussing ultrasound-guided peripheral IV access. I have no financial disclosures. These are the objectives we're going to be covering today, including materials, sonoanatomy, and technique.
This is a really useful skill to know because patients who are difficult to access are not rare. These two studies looked at rates of difficult IV access among ED patients in urban centers. These are patients that needed more than 3 attempts with the standard approach, or an ultrasound-guided IV, or an intraosseous line, external jugular vein cannula, or a central line placement. You can also see that in this figure, patients who had difficult IV access suffered significant delays in their care, including medication administration, diagnostic imaging, laboratory testing, and even disposition. Shakouhi et al. Found that central line insertion rate decreased by 80% in the time period after instituting an ultrasound-guided peripheral IV training program. The percentage of patients discharged from the emergency department after having a central line placed decreased from 13% to 0%.
This slide shows the materials that you'll need. You'll need a high-frequency linear transducer, a sterile conduction medium, which could be Surgilube, sterile gel packets, or even just sterile saline out of a flush, some kind of probe cover, and an IV cannula of your choice. You also need the usual materials that are used to dress the IV, as well as low-level disinfection wipes to clean the probe after use. This is the American Institute of Ultrasound and Medicine practice guideline for probe cleaning. Ultrasound-guided IV insertion falls within the percutaneous procedure category here. You can use the same sterile sheaths that are used for central line insertion if that's all you have on hand. Manufacturers do not recommend using Tegaderm as a cover as they're not impervious to all small viruses. This guideline has been co-endorsed by the American College of Emergency Physicians, American Academy of Emergency Medicine, and the Academy of Emergency Ultrasound. This QR code is for an ASEP page with answers to frequently asked questions about cleaning recommendations. Next, we're going to cover the sonoanatomy of different arm veins that are the typical targets of this procedure. Generally, vascular structures are going to be anechoic and compressible. Veins will be more easily compressible than arteries, and arteries will have pulsatility to them. Neural structures will be non-compressible and may be hyperechoic or hypoechoic depending on the angle that the probe is at the skin. Here is a labeled still and a clip of the brachial vessels at the antecubital fossa. Note here that the median nerve is hypoechoic because of the angle that it is being insunated. With gentle probe pressure, the veins will occlude, but the arteries will remain patent. The basilic vein is a good target for patients that have small brachial veins. I typically find it by sliding the probe medially and slightly proximal to just above the medial epicondyle, and it'll appear as an anechoic circular structure. The basilic vein is usually a deeper vessel, and it's hard to palpate, so I find that in most patients who have difficult IV access, it's relatively still a good target because it hasn't been poked a bunch of times. As you track the basilic vein more proximally in the arm, it tends to increase in size, which makes it an easier target, but does become more closely associated to arteries and nerves. Here's a clip of the basilic vein at the level of the mid-humerus, where you can see neural structures and the brachial arteries to screen left of it. And here's a still and a clip of the basilic vein in the upper arm, where you can see the median nerve, brachial artery, and the ulnar nerve closely approximated to it. The cephalic vein is the third option for a target in the upper extremity, although I don't have as much luck with cannulating it as the basilic vein or the brachial veins. I find that most of the time it is only a good target at the level of the humeral head. If you are having difficulty differentiating a vessel as either a vein or an artery, you can use the color Doppler flows to help decide. Veins typically have continuous flow, whereas arteries will have more pulsatile flow. If you're in a situation where you're using the color Doppler and you can only see pulsatile flow, you can try letting up a little bit of pressure on the probe to see if the veins were being occluded. This is a common occurrence in patients who are hypovolemic. The next clips are going to show the short axis insertion technique. The probe is oriented axially to the vein and the needle is inserted at the middle of the probe, out of plane with the beam. The tip of the needle will produce a hyperechoic artifact that you will follow down with the probe in a stepwise fashion until it appears within the vessel lumen. Once the needle tip is visualized within the vessel lumen, the catheter can be advanced over the needle and the needle retracted. Here is a clip of an insertion on a volunteer. You can see that the pressure of the needle starts to divot the vein's superficial surface. There may be some resistance at this step. The operator then advances the needle until the tip artifact is visualized within the lumen. At this point, I usually lower the angle of the needle to the skin and advance it a couple of millimeters to make sure that enough of the catheter is in the vein. Then I put the probe down and advance the catheter over the needle until it's hubbed. You can also rotate the probe to give a long axis view of the needle to see its relationship to the back wall of the vein. The challenging part of the short axis technique is ensuring that your probe is visualizing the tip of the needle and not the shaft of the needle as it's being advanced out of plane. This graphic demonstrates this. You can see here that our cartoon needle has traversed the vein, and the tip actually lies outside the vein and the soft tissues posterior to it. The appearance of the needle on the screen varies depending on how far away from the tip of the needle the probe is oriented. The thickness of the beam is only about 1 millimeter, so it can be very easy to become confused about where the tip of the needle is if you advance it too quickly past the probe. The long axis approach is a valid alternative to the short axis approach. Here, the probe is oriented in the long axis of the vein, and the needle is inserted parallel to the beam. This allows the operator to see the entire shaft of the needle during insertion. The drawback is that if the probe, vein, and needle are not perfectly aligned, they will not be visible on the screen without fanning the probe. In this clip, you can see that the vein disappears and reappears from view as the operator fans the probe, and that the shaft of the needle is only barely visible at the end of the clip. In the next several clips, we'll discuss some troubleshooting techniques for common challenges with this procedure. In situations where the vein wall collapses with pressure from the needle before the needle penetrates, taking a shallower angle of attack allows the needle to penetrate the anterior wall. Applying a tourniquet to help distend the vessels can also help with this problem. In the short axis approach, if the needle insertion is slightly at an angle instead of at 90 degrees to the probe, the needle tip can enter the vein at an oblique angle that makes it difficult to thread the catheter or miss the vein entirely. This can be amended by backing the needle out until it is just in the midline and then adjusting the angle to the left or the right so it stays in the midline when it's advanced. It can also help to square the probe to the vein along its course within the arm as opposed to the axis of the extremity itself. In this clip, you can see that when the probe isn't squared to the course of the vein, it appears to drift over towards the right side of the screen as the probe moves. This can make it difficult to guide the needle to the vein. This slide summarizes vessel and technique characteristics that have been shown to be associated with successful ultrasound-guided IV placement in the literature. Long catheters are more successful as many veins that are amenable to ultrasound-guided placement are deeper than those that can be palpated. Intuitively, targeting larger veins increases the chances for successful cannulation, and targeting veins that are deeper than 1.5 centimeters is associated with decreased successful cannulation, as a lot of the time the catheters that you're using just aren't long enough to actually get to the vein, even if you can see the target. Counterintuitively, aiming for vessels that are too shallow also decreases the chance of success, because there's not as much space on the screen for you to guide the needle approach. If attempts to cannulate upper extremity veins have been completely unsuccessful, another peripheral candidate is the external jugular vein. To visualize this vein, the ultrasound probe is placed over the SCM muscle, and it can be visualized as an anechoic vessel lying superficial to the SCM. The technique for cannulating the external jugular vein is the same as cannulating any other peripheral vein. Placing the patient in a head-down position on the stretcher, or having them perform a Valsalva maneuver if they can help distend the vein to make it easier to visualize and cannulate. Thanks for listening to this presentation. I hope that it was a helpful introduction or refresher for this skill, which I think is super useful to know. Like any procedural skill, practice is important. I often recommend to the residents that I work with to try this on patients that may not have difficult IV access if they have the opportunity to, so that they can get their hand-eye coordination skills built on patients that might not be as difficult to access, so that when they encounter patients that have difficult IV access, they're not as intimidated because they have that basis of the skill set that they've practiced on patients that were not as difficult to access. Here are my references if you have interest for further reading.